So risk factors for renal calculi. So whenever the child is in dehydration, so when there is low urine volume, when it is an acidic urine will favor the formation of renal calculi. When there is high sodium intake, which we have already seen, high calcium in the blood, high oxalate and high urate will all promote the stone formation. Okay. Which are all protective factors against the stone formation? So one is citrate protects, magnesium will protect, glycosaminoglycan will protect and osteopontin. These will inhibit the stone formation. So this you should definitely know. Okay. And stone formation again will depend on 4 factors. One is the matrix. Matrix means it's a mixture whereof it's made up of protein, water, all those glycosaminoglycans. Epitaxy, when there is crystal aggregation it is necessary, and when there is absence of inhibitors. See, when there is no citrate, no magnesium, then there will be formation of stones. So these are all images of the various stones. Calcium stone is the most common, that is 80% will be calcium stone. This is the struvite stone or the staghorn calculi. So this is the staghorn calculi. Next is the uric acid stone, and finally this is the cystine stone. So clinical manifestations will depend on largely about the position and about the size of the calculi. So manifestations will be like hematuria, it can be gross or microscopic hematuria. There can be pain. So the pain is predominantly because of an ureteral presence. So it can either be a flank pain or an abdominal pain when the calculus causes obstruction. And where there can be obstruction is where there are narrowing of the ureter. Okay, so in the ureter, the narrowing can happen at areas like uretropelvic junction, where there is crossing of the iliac vessels, and in the uretrovesical junction. This uretrovesical junction is going to be the narrowest, where the ureter actually enters the bladder, that is the narrowest. And this pain, whenever there is obstruction, this pain can radiate, and it radiates to scrotum in males and labia in females. Pain will be intermittent, and once if the stone has passed out of the system, that pain will be relieved by the patient. And if it is in the distal ureter, typically it will give manifestations like an cystitis or an urinary tract infection. There can be dysuria, urgency and frequency of urination. Okay. So sometimes not almost similar, very much like adults, but there can be passage of stones that the patients can tell us, and small gravel like material will be passed out. See here, you can see that left ureteric calculi, there are multiple radio opaque calculi which is seen in this X-ray imaging, erect X-ray imaging. So 90% is radio opaque we know, so we do a X-ray imaging, and what is the gold standard or what is the most accurate one is a spiral CT. Okay. So an unenhanced spiral CT scan of the abdomen and pelvis is most accurate. It is sensitive up to 96%. If you are not able to do spiral CT because of any reason, what we can do is we can do an X-ray abdomen along with an renal ultrasound. Renal ultrasound, again the disadvantage is if the calculus is not very close to the bladder or pelvis, we cannot visualize it, and if the calculus is very small, say less than 3 mm also, it is not seen. Okay, and this is an ultrasound which is showing a staghorn calculi. Coming to the follow-up, if the child is already diagnosed, what we can do is we can follow up with serial ultrasounds because we cannot subject the child to serial X-rays, right? So serial ultrasound will be better when compared to serial X-rays. And any material that is expelled which resembles a calculus should be immediately sent for lab evaluation, because we want to identify if the child has any metabolic underlying disorders. So what are the investigations that you are going to do? We know that calcium, that is hypercalciuria, is one of the common factor for renal calculi. So we do a serum calcium and urine calcium creatinine ratio. So this has to be definitely done. And apart from that, phosphorus alkaline phosphatase is done, uric acid, urea, creatinine, serum electrolytes, anion gap are other ancillary investigations. When it comes to urine, we do a urine routine and urine culture, because if it is a struvite stone, that is the triple ammonium phosphate stone, it will be associated with urinary tract infections, especially of Proteus, Klebsiella, etc. So you do a urine routine and urine culture. Calcium creatinine ratio, yes, definitely for all cases. Spot test for cystinuria, if it is suggestive of a cystine stone, then we can do that. And apart from that, 24-hour creatinine clearance, urine calcium, urine phosphate, urine oxalate, etc. It's depending on the what kind of stone that we have obtained.